So good evening all. Welcome everyone to the Kerala TJ case presentation discussion series conducted by IRIA Kerala in association with Genomed. And for this, I welcome Dr. Gomadi Subramanian, President Kerala IRIA, Dr. Rijo Matthew, Secretary Kerala IRIA, and Dr. Ramesh Shanai, Program Coordinator. Today, the program is being moderated by Dr. Rashmi CP, Consultant Radiologist in Anandaburi Hospital and GG Hospital, Trivandrum. Welcome, Dr. Rashmi. And our faculty is Dr. Ajit Toms, Senior Consultant and Radiologist, Head of the Department in Rajagiri Hospital, Kochi. I welcome Dr. Ajit Toms. Now over to Dr. Rashmi for the introduction of the faculty.
A very good evening to you all and welcome to our academic session. So this week also we'll be continuing musculoskeletal imaging. So today our faculty is Dr. Ajit Toms. He is head of department of the Tertiary Multi-Center Hospital Rajagiri in Ernakulam. He has completed his MBBS from Kottayam Medical College and post-graduation from the prestigious St. John's Hospital, Bangalore. And he is working in Rajagiri for the last 8 years. So he is a faculty of National Board of Examination and also a DNB examiner. He's actually more interested in the technology and the physics related things. So he'll actually explain to it. So, and today we have two residents from Rajagiri Hospital, Dr. Preeti and Dr. Balashankar. Both are secondary DNP candidates in the hospital. So today we'll be discussing the musculoskeletal cases. So over to you, Dr. Ajit, for the case presentations and the discussion. Over to you, sir.
Thank you, Dr. Rashmi. I hope I'm audible well enough.
Yes. Yes.
So first of all, let me thank IRIA Kerala and President Dr. Gomadi Madam, Rijo Sir, Dr. Shenai, Dr. Venu, and Dr. Rashmi for giving us this opportunity. We have not been part of these academic programs for the last few months, but I have gone through the recorded versions and I found them to be very useful, and I've asked our PGs also to go through them because it's really useful. And I'm glad that we've been given a platform to showcase one or two cases of ours. And I hope that this is going to be beneficial to the PGs who are listening to this. Dr. Rashmi, thanks for that introduction. When I said technology, I just meant that I like the physics part. I always wanted to be an engineer and then just happened to be doctor. So that is the case, and I do a little bit.
You are welcome to take physics related and technology related classes for Kerala.
Maybe like later. But anyway, so let's get on with these sessions today. We have Dr. Preeti Jose and Dr. Balashankar, our PGs from Rajagiri, for the case presentations. And I'm going to share my screen with the first case. So Dr. Preeti is going to present the first case, and she is the final year secondary PG. So the first case is a 23-year-old male, and he complains of right knee joint pain for the last 6 weeks. He has got a history of twisting injury with a popping sound 6 weeks back. Now coming with difficulty in walking and bending. On examination, tenderness along the medial joint line and painful R1. So Dr. Preeti, what would you think of what are we looking at when we hear this history?
So we are looking at a pathology related to the knee joint, particularly involving something which involves the medial joint line. So I'll ask the clinician's first step would be to do a X-ray knee, preferably X-ray knee, AP and lateral.
All right, so we have the right knee, AP and lateral. What do we see here?
So the right knee, X-ray, AP and lateral of a skeletally mature patient showing a grossly normal morphology of the femur, trochlea, femur, tibia, fibula and patella. The prepatellar fat plane, this shows a soft tissue density. However, there is a relative sparing of the fat planes. The infrapatellar fat plane, that is a Hoffa's fat plane, is normal. And there is no obvious fractures or dislocations. The rest of the soft tissues appears normal.
Okay, so for internal rearrangements of knee, we don't usually see much of changes on X-rays. Now,
Yes,
what is this additional view that we are showing?
So this is a skyline view.
All right, and what is this done for?
So this is usually for assessment of the patella because we are able to see the patellofemoral joint space properly.
Okay, and any findings here?
So we are seeing a well corticated radio opaque opacity in the medial patellar femoral joint space.
And what do you think it could be?
So either it could be a loose body or it could be a displaced subchondral fracture fragment. The rest of the patellofemoral joint space is maintained. The rest of the patellar morphology appears normal.
Okay, so when we see a loose body like that, we'll have to go back and see whether there are any osteochondral defects of the condyles
Yes,
that we're not seeing, and then also of the patella.
okay, sir.
Right, and we can see the margins of the patella quite well.
Okay.
Cartilage surfaces, of course, are not seen on X-ray. So what do we do next now?
Sir, I would advise the physician. I would advise the physician to go ahead with a MRI knee because that will delineate the ligaments and the meniscal clearly.
All right. So now I'll stop sharing, and you can start showing the MRI images from PACS.
Okay, sir.
Right. So can you just tell us what all images, what all sequences we have done?
So we have done a T1 sag, coronal, and axial, and we have done a PD fat sat of the axial, sag, and as well as that of a coronal, and then we have done a T2 sag and a T2 gradient FFE. So I'm taking the axial fat sat, PD fat sat images and T1 fat sat images. Here we can see that there is some subchondral osseous edema that is involving the lateral femoral condyle as well as that of the medial aspect of the patella. On the T1 images, we could appreciate a subchondral fracture. Then there is associated chondral defect is seen in the medial patellar facet, and there is another osseous fragment that is seen in the medial patellofemoral joint space. So this case is also associated with knee joint effusion. When you look closely at the medial aspect of the patella, we are able to see some PDF hyperintensities, and the medial patellofemoral ligament, there is some discontinuity at the patellar insertion site. And on, so this is the PD sagittal images. Here we can see that there is a, okay. So I have also put the gradient images. Here we can see that there are, okay, there is a T1 hypointense loose body is seen in the anterior as well as that in the posterior joint space. So this could be a loose body or a displaced osteochondral fragments. Then the rest, I'm going through the rest of the ligaments and the menisci. It is relatively maintained and unremarkable. So the rest of the soft tissues appears normal, and the rest of the muscles and tendons also appears unremarkable. So I'll conclude by saying that we can see that there is some subchondral osseous edema involving the lateral aspect of the lateral femoral condyle as well as the medial aspect of the patella with associated subchondral fracture and a displaced fracture fragment. Then there are loose bodies also in the anterior as well as that of the posterior joint space. This is also associated with a chondral defect in the medial patellar facet, as also there is discontinuous, the medial patellofemoral ligament is discontinuous at the patellar attachment site. So I would say, and there is also mild joint effusion. I would like to say that these could be secondary to changes related to a recent patellar dislocation.
Okay. So why do you say that it is a patellar dislocation, and how do you say that?
Sir, when there is a patellar dislocation, what happens, and that in a lateral patellar dislocation, so the patella will be dislocated laterally, and the medial aspect of the patella will be in close contact with that of the lateral femoral condyle. So that is why in this patient we are seeing a osseous edema at the medial aspect of the patella as well as the lateral femoral condyle. And there are associated findings which contribute to a recent patellar dislocation. That is the mediopatellar ligament. There is some discontinuity here along with PDF hyperintensities. And also there is some subchondral defect that is at the medial patellar patella. And I would also like to point one that is to say that the Hoffa's fat pad is relatively maintained in this patient.
Okay.
Usually that will be associated in a case of patellar instabilities.
All right. So, so you have concluded that this was a post-patellar dislocation changes, and the fact that there are a few loose bodies would mean that it could also be that it is not the first time it has happened. It's probably, yes, although we've not got that history. Now, can you tell me what are the reasons why we have an unstable patella?
So there are basically because of anatomical morphologies, abnormalities. First one may be the trochlear dysplasia. We need to see whether there is any trochlear dysplasia. Then patellar alta. Then other causes will be lateralization of the tibial tuberosity. Then there can be because of the laxity of the ligaments. Then it can be because of patellar tilt defects. Then there are other reasons also that we need to see.
So what do you call this together, the group of all these disorders? If you are to put it in one basket, what do you call it?
Patellar maltracking.
Okay, so can you just describe how the patella tracks and where does it articulate and how does it track along the knee joint as you bend your knee?
So the patella is articulating along the femoral trochlea. That is, so this is the femoral trochlea, that is the medial and the lateral aspect, and this is the patella. So when the patient is on zero flexion, the patient is only when the patient is on complete extension, there can be if at all there is a patellar dislocation, the chance for more patellar dislocation will be when there is an extension, in complete extension. While we are flexing, the patella will engage into the trochlea.
All right. And if you have to assess for trochlear dysplasia, what all quantitative methods do we have?
So to rule out trochlear dysplasias, we usually follow, we need to see 4 parameters. The first one will be the trochlear depth. The second one would be a lateral inclination angle. Then the facet, whether there is any facet asymmetry. Then also we need to look at the morphology of the trochlea, that is by Ridgejob classification.
Okay. Now, can you stop sharing? I'll just start my slideshow.
Sure.
So as Dr. Preeti has said, so this was a case where we see this subchondral edema on the lateral femoral condyle, and there is a corresponding defect on the medial facet of the patella with an osteochondral defect, large osteochondral defect, which has got displaced into the medial patellofemoral joint space. That is what we saw on the X-ray. What we didn't see in the X-ray was that there were a few more loose bodies in the posterior part of the joint. So all these points towards a maltracking abnormality of the patella. And the reason why it maltracks could be many. So as you know, the patella engages with the trochlear part of the femur, and it's like a wedge. So it's like the patella gets wedged in that groove. So as Preeti was saying, when the patellar dislocation usually happens when the patient is fully extended knee, that is when the patella is at the topmost, the superiormost part of the patellofemoral compartment, and there the trochlear groove is quite shallow, and that is one reason why you have a patellar instability. So we have some measurements for the trochlear groove depth. So one is this, we usually take measurements at about 3 centimeters from the joint line, because that is the superiormost part of the joint. And here we take an average of the anteroposterior dimensions of the medial and the lateral and medial condyles. We take an average and then we subtract it with the measurement from the trochlear groove, and that is called the trochlear depth, and it should be more than 3 millimeters. So if it is less than 3 millimeters, here I think we got around 2.8, which is slightly shallow. So that is one method of identifying trochlear dysplasia. The other, what are the other methods?
So the next one would be a lateral trochlear inclination. Here we need to put a one. So can I?
Yeah, so here what we do is that we draw a line through the chondral, the osseous surface, not the chondral surface, the osseous surface, because that is more well defined, of the posterior condyles at that level at 3 centimeters. So that is one line drawn, and then we draw a line parallel to the lateral part of the trochlear groove, and we draw the plane along that and see what is the inclination. So if it is a very shallow inclination, obviously this won't hold back the patella, and then it gets displaced laterally. So that is one sign of trochlear dysplasia. The other being a very asymmetric facet, where we have a very small facet on the medial side and a longer facet. How do you measure that, Preeti?
So we need to measure the medial part of the trochlea to that of the lateral part. Then we need to take the percentage. So in this case, it is like 1.52 divided by 2.74. So we got around 56%. If it was less than 40%, then it is sure cut that there is a facet asymmetry.
Okay, so these are the signs of trochlear dysplasia. And then the other things that we have to look for. So trochlear dysplasia is one anatomic variant when the knee joint or the patellofemoral joint becomes unstable. The other quirks of anatomy or the changes of anatomy would be a high placed patella. So how do we measure that? I think we all know how do we do that. We do that on X-ray. So how do we do that on MRI?
That is also by insult-Salvati ratio. The first one is insult-Salvati ratio. In that, we need to measure the patellar ligament length. That is from the inferior pole of the patella to that of the inferiormost portion of the patellar ligament. Then that divided by that of the patellar length. That is the line joining the inferior and the superior pole of the patella. So if it was a case of a patella alta, in insult-Salvati ratio would have been more than 1.3. Then there are other indexes. The first one, the next one being the Caton-Duchamp's index. Here what we do is we draw a line from the, we are measuring the maximum length of the articular surface of the patella. So that is what we are showing in this image as 3.4. So the superiormost portion of the articular surface to that of the inferiormost portion of the patella. Then another line is drawn from the inferiormost portion of the articular surface of the patella to that of the anteriormost tibial spine, anteriormost part of the tibial plateau. And then we are again dividing. In this case, we got around 1.03. If it was a case of patellar alter, then it would have been more than 1.2.
So suffice to know is that if you have a very high placed patella, it actually becomes quite unstable because it goes very high into the trochlear groove and where it is very shallow. So basically the resting place of the patella becomes very unstable. So that is the importance of the patella alter measurements that we do. There is also another method by which we just look at the amount of articulation between the entire, the percentage of articulation with the femur compared to the total length of the articular surface of the patella. So if we have a very short area of articulation in the resting extended knee joint, that means that again it is a very high place. These are different methods of measuring for patella alta, but I think we'll stick to insolsalveity because that is something that we all do regularly. Right, and then this is a concavity, the DiGeorge classification, basic symmetry. We've gone through this. So the third part, again, variant anatomy that we have to look into. It's not necessary that all these things can happen in the same patient. You know, you can have a trochlear dysplasia, or it could be a patella alta, or it could be something called a increased tibial tuberosity to the trochlear groove distance. Now, what that means is, I'll just show you. Now we know that the so we know that we have the quadriceps muscles here, and then it is getting attached to the patella, and then we have the patellar tendon, which is coming and attaching to the patellar, so the tibial tuberosity, and so therefore this forms an angle. So this is also called the Q angle. So what happens is that you have force acting on patella like this, and then there is a reactant force acting like this as well. So there will be a small resultant lateral force which is actually pulling the patella to the lateral aspect. Now suppose this attachment is more lateral, again somewhere here, then the component will increase. So then you will have a more lateralized force on the patella. So this is also assessed by the trochlea to the to the tibial tuberosity distance. That is actually the absolute distance. So we take a measurement of the groove here, and then we take the tuberosity measurement here, and what is the actual lateral displacement that we see. So that is the idea about the TTTG distance, and usually it should not be more than how much? 20?
So it should not be more than 2 centimeter.
It should not be more than 2 centimeters.
If it is more than 2 centimeters, it is clear cut. Usually it should be less than 1.5.
Right. So that is, so this is the third thing that we look for in a patellar instability. So again, the TTTG is what we quantify the Q angle with. And if you have something more than that, then it is quite sure that there is a more lateral pull on the patella, and therefore it is inherently unstable. Then, of course, comes the stabilizers. So we have the anatomic variants. We talked about trochlear dysplasia. We talked about high placed patella. Then we have increased TTT. These are all fixed congenital issues the patient has as they're growing. But suppose for no other reason, even without all these reasons, he's had or she has had dislocations, then we could have a patellar. The reason for recurrence would be because of the patellar femoral ligament laxities or tears. And so here in this case, although we have a patellar trochlear dysplasia, that could have been the reason for the first episode of lateral dislocation, but we also have some weakening of the medial patellofemoral ligament as we see here, because we see some hyperintensities at the patellar attachment. And some of the other things that we have to look for is like, these are reasons, the patellar instabilities are also reasons for anterior knee pain. So sometimes you might not see anything, but you might see just the Hoffa's pad fat edema towards the lateral side. And this is because it impinges on the lateral tuberosity. So that these are the things that we have to look for in addition to what we already looked for, right? So I think with this, so the final diagnosis here is that we have had a post patellar dislocation changes, and that is shown by the subchondral fracture of the medial patellar facet with the loose bodies and some mild joint space fluid. We also secondarily looked at the reason for that patellar dislocation. That is, we see that there is a trochlear dysplasia seen because we saw that the trochlear groove was shallow, and then the angle was less than 11 degrees. And then there is also an additional reason why he could get recurrent dislocation, that is the grade 2 sprain of the medial patellofemoral ligament. Now, Preeti, how do we treat this?
So because of this, because in this case there are loose osteochondral bodies, we need to operate this, but not immediately. It can be in a staged manner. So this patient has been posted for surgery, and this is all because of there are loose osteochondral fragments. If it was not so, then we could have first tried for some conservative management.
Right. So mostly patellofemoral ligament repair is what they do, along with removing all these loose bodies. But in case if there is an increased TTTG, they can also do a transfer of that tendon to more distally as well as more medially, so that that TTG distance becomes less. And of course, if the trochlear groove is very shallow, then you can also increase the depth of the trochlea by removing the subchondral bond there. But these things are not regularly done. What is mostly done is the medial patellofemoral ligament repair. So I think we've done with the first case. So before that, the patellar maltracking, the MRI checklist is trochlea. Look for any, first of all, identify that it is a post patellar dislocation changes. And then we have to look for the trochlear dysplasia, where you look for the depth, the inclination, and the facet asymmetry. Look for the patellar alta, lateralization of the tibial tuberosity, that is the TTTG distance, and the lateral patellar tilt. The additional signs of, these are signs of a unstable patella would be a Hoffa's pad fat impingement and MPFL injuries. So we've finished with the first case. Shall we move on to the second one?
Yes, sir. Yes. You actually covered everything in this patellar dislocation case. So the discussion part was excellent. And Preeti also actually, she presented it very well. She was very confident in presenting. So well done, Preeti.
Thank you.
Thank you.
You can go to the next case.
Right. For the second case, it is actually not a very complicated case. So why I chose this case is because I've been to 1 or 2 DNB exams, and I found all the candidates to be very well versed with all the other systems. And I just happened to take 1 or 2 musculoskeletal, and when it comes to musculoskeletal, they are a little apprehensive. It's not because they don't know, but probably because they don't report it that much. So I thought I'll just discuss a simple case as well. So so this is for Balashankar. So the clinical profile is that it is a 40-year-old male presented with complaints of pain and locking right knee. On examination, medial joint line tenderness was positive, and there was an anterior drawer test which was positive. Now, what do you make out of this clinical history, Bala?
So the patient has suffered some injury, probably ligamentous injury to the knee, which is indicated by the medial joint line tenderness. And the positive anterior drawer test indicates a probable injury to the anterior cruciate ligament.
Right. So we've been long past our clinical medicine, but I'll still ask you, what are the other, some of the tests that we do for knee joint? If you can just enumerate a few. It's not that I know all of them, but
Yes. Apart from the anterior drawer test, we have the pivot shift test. And the examination of the joint line tenderness.
okay, what is that? That is the McMurray sign. So when you look for joint line tenderness,
Yes.
and you spoke about anterior Doyer sign, but sometimes they also write Lachman test positive.
Test, yes.
What is that?
So in both these tests, we are basically checking for the abnormal anterior translation of the tibia compared to the fibula. The only difference is in the positioning of the knee joint. In the anterior drawer test, the patient is in supine position with the knee flexed 90 degrees, with the examiner trying to translate the tibia anteriorly. Whereas in the Lachman test, the patient is in a supine position with full extension of the knee joint. And again, we are checking for the anterior translation of the tibia related to the femur.
All right. So just remember, if it is McMurray positive, it is something to do with the menisci. If it is Doyer sign positive or Lachman positive, it is with the ACL or right, post PCL as well. So going to the next. So here I'll just stop sharing and then you can start. So what do we do now? Do we need to do an X-ray?
So since we are suspecting a ligamentous, probably crucial ligament injury, plain radiograph is usually not very informative. We might find some avulsion fractures like the ACL attachment, femoral or tibial side avulsion fractures, or some secondary signs like Segon fracture, arcuate fractures, etc. But better would be to evaluate with an multiplanar MRI imaging.
All right. So then we've done that, and can you just share those images?
Yes.
So again, please start with the sequences that we have taken.
Yes, sir. For this patient, we have taken a T1 SACH, T1 coronal and axial. That is in all three planes. We have taken the T1 weighted sequence, and we have a PD fat.
This T1 that we have taken is actually, we have taken it in a sagittal,
Yes,
thin sliced
section
images, where we have reconstructed the coronal as well the axial. So we've not taken three separate sequences. It is just one sequence that we have reconstructed in the other planes.
Yes.
So carry on.
Apart from the T1, we have also taken the PD FATSAT sequence in the axial, in the sagittal, as well as the coronal planes. And we have the T2 and the T2 gradient FFE sequence in the sagittal planes.
Right. So can you just describe the findings?
Yes. Starting with the thin T1 weighted SACH sequences to look at the bones. I couldn't find any obvious fractures, any hypointense lines in the femoral or the tibial articular surfaces or in the patellar surfaces to indicate any fractures. I couldn't find any subchondral insufficiency, any subchondral fractures or any depression of the articular surfaces. The articular surfaces appear congruent. There are no obvious loose bodies for which I would like to check the gradient sequence as well.
Mm-hmm.
No obvious loose bodies could be identified in the anterior or posterior joint space.
Right.
There are no obvious avulsion fractures.
Right. Now, suppose there was a effusion.
Yes, sir.
Fracture and then an effusion. What do you see? What sort of an effusion is it?
There can be lipohemocrosis indicated by layering type of effusion in the joint space with T1 hyperintense contents indicating blood components.
Is it the blood component?
Clotted blood.
Yeah, you can also have fat floating.
Yes.
Right? That is T1 hyperintense. So that will also be T1 hyperintense.
Yes.
Okay. Now move on to the next sequence.
Now moving on to the SACH PDFS and the axial PDFS sequences. So first, examining the cruciate ligaments. So this is the anterior cruciate. We can see that the femoral attachment of the anterior cruciate ligament is poorly delineated and is replaced by fluid signals, likely indicating complete tear of the femoral attachment of the ACL.
Can you trace the ACL?
Yeah, so this is the tibial attachment of the ACL in the anterior tibial plateau, which appears intact. However, tracing it superiorly, there is hyperintense signal of the anterior margin of the ACL, which is formed by the anteromedial bundle, which is usually hypointense normally in all cases. Here it is replaced by hyperintense signal, which again indicates injury. And tracing it further superiorly, we couldn't find a definite insertion into the femoral intercondylar notch with fiber discontinuity and replacement by fluid signal, suggesting tear of the ACL.
Is that confirmed with the axial images and the other images, coronal images?
Yeah, so on the axial images, this is the lateral, this is the medial aspect of the lateral femoral condyle.
So can you tell us where these this ACL attaches?
Yes, the ACL superiorly attaches to the medial aspect of the lateral femoral condyle and then runs obliquely downwards to insert on the anterior aspect of the anterior aspect of the tibial plateau.
That is also the reason why it is slightly oblique.
Oblique in course, yes.
Yes. So nowadays we have the 3D sequences, but earlier we used to image the knee in slightly what position so that we could get a true sagittal images through the ACL.
Oblique planes along the axis of the ACL.
We could also do a slight external rotation so that the ACL would become more sagittal to the MRI board. Okay. Anyway, so that is it, and so we are seeing some fluid between the PCL attachment of the PCL as well as the ACL ligament. So that is also a sign that is an empty region there, no, where towards the femoral attachment. So that fluid that we see between that is also a sign that the ligament is torn.
Yes.
So then we have the ACL injury. So you're saying it's a full thickness ACL injury. So what do we do next? Now, once we see that the ACL is gone, what are the other structures that we have to look for?
We can look for associated injuries that are commonly seen along with ACL tear. Basically, we can look for bony contusions. Typically, the pivot shift pattern of bony contusions are seen in ACL injuries, which are seen in our case as well. There are bony contusions in the lateral, in the middle aspect of the lateral femoral condyle, as well as in the posterior medial aspect of the lateral tibial plateau. These are typical pivot shift bony contusions, which are commonly associated with ACL injuries.
What happens when the ACL is torn? So what sort of a translation happens? What sort of an instability happens with the knee?
So basically, ACL is a ligament which prevents anterior translation of the tibia as compared to the femur. So disruption results in anterior translation of the tibia, which is considered significant if it is more than 7 mm.
Okay, and that is also the cause for the as well, because the posterior part of the tibial condyles will go and hit the femoral condyle. That is the reason why we have the femoral edema to be slightly anterior, while the tibial edema is posterior. And there is a torn, there is a translation, and then you have the edema.
Yes.
So, but in this case, can you say whether this is an acute injury or subacute injury or chronic injury?
With the bone marrow edemas and the signals of the ACL and the significant associated joint effusion, I would consider this as an acute injury, sir.
Right. Yeah, maybe or a little subacute because the edema has slightly subsided. Okay. what are the other structures? And what is that triad that is known as that happens with the ACL injury?
And there is an O'Donoghue unhappy triad.
Yes. So what are the other structures that we have looked for?
There are two other structures in this triad apart from the ACL, which include the medial meniscus as well as the medial collateral ligament.
Okay. Okay. Before we go into that, what is the other cruciate? Do you have to say anything about that?
Yes, the posterior cruciate ligament, its femoral attachment appears intact, but coming to its mid and distal attachment, there is significant loss of fiber discontinuity and replacement by fluid signal, which again suggests a near full thickness tear of the mid and lower aspects of the PCL.
Right. So PCL injury is less common than ACL because ACL is inherently weak, and this is like an uncommon injury because we have both the cruciate being injured.
Yes.
Anyway, we'll leave that right now. What is the usual other ways of PCL injuries apart from mid-substance injury that you've seen?
Yes. Since the ligament itself is fairly strong, the usual type of PCL injuries are the avulsion injuries. That is avulsion of the tibial foot plate of the PCL.
Right. That is because the PCL is a very strong ligament and it can actually pull off the bone rather than it being torn itself. Right.
Yes.
Right. So, okay. Now coming to the other structures.
Yes. Now coming to the meniscal structures, this is the lateral aspect of the knee. This is the lateral meniscus with its botte configuration. There are no abnormal anatomical variations like the discoid meniscus.
Now, when do you say it's discoid?
Discoid meniscus is when the body of the meniscus measures more than 15 mm in height, or when the thick configuration, that is a non-botte configuration of the meniscus, persists for more than 4 slices on the sagittal sequence.
15 mm in height, or is it that lateral? It's the transverse dimension, isn't it? Because instead of a ring, it becomes a disc.
Yes. Yes.
Right. So more than 3 or 4 slices.
Yes.
You can still see it. Then it is a discoid, and that is prone for injury. So any injury here?
No, sir.
Okay.
The meniscal configuration appears normal. There is mild linear PDFS hyperintensity coursing through the substance of the posterior horn of the meniscus, which is not extending to the femoral or the tibial articular surfaces. So this is likely type 2 intrameniscal signal alteration.
All right. Now coming to the medial.
Yes. Coming to the medial meniscus, there is significant PDFS hyperintensity as well as signal alterations of the posterior horn as well as the body of the medial meniscus, with a part of the medial meniscus being flipped into the intercondylar notch and coming to lie anterior to the PCL, resulting in the double PCL sign.
Okay, so what does that indicate?
It indicates a bucket handle tear of the medial meniscus, sir.
Okay, can you show that on the coronal images? So what we see is that we have a truncated meniscus,
medial meniscus, sir.
And then you can actually trace the flipped.
Yes.
Movement.
This is the flipped fragment lying in the intercondylar notch anterior-inferior to the PCL.
Right, and you can actually look for the continuity with the anterior and the posterior horn. So if you trace that fragment, you can see that it is continuous with the anterior horn, and as you trace it back, you'll see it continues with the posterior horn. When we know that it is a bucket handle tear of these things. Now, what are the other structures that we have looked for?
The other structures that can be seen on the sagittal images. We can assess the.
No, the other ligaments.
Yes. The ligaments are better appreciated on the coronal and the axial sequences.
Mm-hmm.
These are the lateral patellar retinaculum and the medial patellar retinaculum, which appear intact with preserved signals.
What about the collateral ligaments?
These are the collateral ligaments. This is the medial, this is the lateral collateral ligament, which shows mild PDFS hyperintensity in its at its femoral attachment, likely indicating a grade 1 sprain of the LCL. And the medial collateral ligament also shows PDFS hyperintensity in at its femoral attachment site. And there is also associated hyperintensity at the posterior medial corner of the knee, which can also be appreciated on the axial images. This is the medial collateral ligament showing hyperintense signal, and the hyperintense signal are extending along the posterior joint capsule to involve the posterior medial corner structures as well.
Which corner is more important?
The posterior medial corner injury is associated, usually seen with ACL injury.
Yes, but that is a capsular injury. But we have to pay more attention to which corner?
Posterolateral corners.
Yes. So can you just tell us what are the structures in that region?
The posterolateral corner is formed by the popliteus muscle and tendon lying in the popliteal hiatus. Then the lateral collateral ligament of the fibular collateral ligament.
Right.
Then we have the posterior joint capsule.
Right. We also have the arcuate ligament and then the popliteofibular ligament. These are all small ligaments. I don't think it's usually well seen on MRI. But if we have to say that there is a posterolateral corner injury, what all things are the major signs? What are the major signs of a posterolateral corner injury? One is a
hyperintensities of the structures.
Right. The capsule might be thickened.
Yes.
The popliteus tendon might be torn, or the lateral collateral ligament will be torn.
Yes.
And then some avulsion fractures like the ones that you had mentioned. You said that you can see it on X-ray.
Yes.
The arcuate fractures. No, the arcuate fracture is a small avulsion fracture of the fibula head.
Yes.
So these will point towards a posterolateral corner injury. You can also see edema of that the capsule there, and as well as edema seeping out, of fluid seeping out to the back of the popliteus tendon. So when you see that, then you think about a posterolateral corner injury, and that is very important because that requires a surgical correction.
Okay.
Right. Anything else? We also have to look for loose bodies. You've already checked that out with the FFE sequences.
Yes.
Look for any patellar injuries.
Yes.
We've checked all that. We've looked for the muscles as well.
Yes.
Right. So then what is the conclusion here?
So to conclude, there's a full thickness tear of the femoral attachment of the ACL. There's a tear of the mid and the distal portion of the PCL. There is a bucket handle tear of the medial meniscus with flipped fragment lying in the intercondylar notch, simulating a double PCL sign. Then there is associated bony pivot shift type of bony contusions involving the lateral femoral condyle and the posterolateral tibial condyle. There is a grade 1 sprain of the lateral collateral ligament and sprain of the medial collateral ligament, and likely injury to the posterior medial corner structures. There is associated moderate joint effusion in the knee joint extending to the popliteal fossa as well as the suprapatellar recess.
Right. What is a degenerative tear of the medial meniscus? Where do you see it?
Degenerative tears are usually seen in the posterior horns, so at the site of the root insertion.
Okay, can you trace the root in this case?
This is the body and this is the posterior horn.
That is the lateral meniscus. And medial meniscus also always. So if you're not seeing anything obvious in the meniscus, but do make sure that the posterior root is also traced up to its attachment.
Yes.
You also have to look for the condylar cartilage abnormality. So if you're seeing lots of condylar cartilage irregularities and all, it's also common that you might see root tears. And associated with root tears, there will be displacement of the meniscus. What will happen? There will be extrusion of the meniscus. Either if it is a lateral, then it's more laterally, and if it is medial, it's to the medial side.
Okay.
So I think we're done with this presentation, with this case. I don't really have anything to add. Dr. Rashmi, what do you say?
Yeah. Actually, you've covered everything. So that was a really wonderful session on this MRI knee joint. I think it is very useful for the residents. So let me tell that your approach to a case was excellent. So you're starting from the history, and from the history, actually, you're trying to point out like what is the abnormality, like whether it is ligamentous or a bony fracture or dislocations. And from that, you're going to the whether X-ray or mRNA and the examination findings. You specifically ask for that examination findings, but now like even the clinicians actually is very reluctant to examine the patient. So I always ask my radiology residents to go and see the patient and actually, if possible, examines. Actually, that gives a lot of clue. So we actually have given importance to all these points, just like be a clinical radiologist rather than just seeing the images. So the whole approach was excellent. Actually, all the residents should actually learn from this. And I felt like you're just like a physicist. Like when you're explaining the cases, that the lateral force, this force, you are actually going through the exact cause of each pathology. So again, that actually helps in actually more understanding the case, and for we radiologists, that is also very important. And the PTs, both of them actually have presented very well. I think all the questions were answered, right? Because they've really prepared well for this. So well done, Dr. Bala and Dr. Preeti. I think you have covered almost all points. Like I don't have any extra points to be covered. And one point I always want to mention that look for the pattern of bony contusions in any, especially in MRI knee. So that really gives a clue whether like you're showing this kissing contusions, the pivot shift that you have described. So from that itself, like when first view, actually we can actually see even without looking at the meniscus, the ligaments, actually that gives a clue. So always there is a good radiographic journal which describes all these typical bony contusions in knee joint. Actually, that's very important. That's one extra point that I need to just tell the residents. Otherwise, like everything is covered. Venu sir, anything else to be added?
Yeah, Rashmi, you told everything. As you said, no, everything was presented in a systematic manner, no. And also this can be kept in the exam, no, DNB practical exam or MD practical exam. This actually this ligament tear, then meniscal tear and all. And also it has got practical point of view also. I think it's very important, because when you start reporting after passing the exam, now most of the time you will just come across this sort of joints and injuries and all. So it's very important, and also a very good presentation. As Rashmi said, both residents actually fared well, and they were very confident. And the anatomy also, each part of the very trivial anatomy also you explained. Very good. Thank you very much.
Thank you, sir.
Thanks a lot, sir.
Yeah. So I think is there any? There are no questions in the question answer session. No. I think like you explained everything. That's when there is there is no doubt from the attendees also. So thank you so much, Dr. Ajit. It was really very useful session for the residents, and thank you, Dr. Bala and Preeti, for that wonderful presentations. So our next MSK session will be the last MSK session will be this Friday. Again, it will be on knee joint, because we covered a lot of shoulder. So this week we thought we'll cover knee joint. So we have a faculty talk by Dr. Danish this Friday. So please do attend. And thank you, Venu sir, again for that opening remarks, and throughout the session you were there, and thank you, sir. And thank you, Gomati ma'am and other office bearers. Thank you, Ramesh sir, for the whole background support, and thank you, Soumya. Again, there was no technical glitches, and everything went so smooth. So thank you, attendees, for attending our IRA academics regularly. So that's all. I think we can wind up the session, right, sir?
Yeah.
So
Yes.
thank you once
Good
again,
night.
Dr. Ajit and residents. Thank you so much.
Thank you.
Thank you, sir.
Good.